after the rapid palatal expansion, I try to understand how he wants to bite, and he wants to bite like this. In this way, for him is a good position to bite the food, to keep the mandible. It's not acceptable. So I'm looking now for the centric relation. The centric relation is this, but in centric relation is touching only in one point, the palatal cusp of the upper right permanent incisor is the only point which is touching. So it's not stable. Actually, I don't like how he bites above. I don't like how the teeth look like in centric relation below. I know very clear that what I would like to have. I would like to have a class 1 in both sides. So, as you see, there is no improvement after the expansion, and not even in centric relation. In centric relation, of course, the joints are well positioned, but the occlusion is not acceptable. I want the lower midline here. So what I do, I manipulate the mandible. I bring the mandible from the position where it wants to stay below, and I place it where I want, above. And I want to stabilize this position with the molars in class 2 with the resin bite blocks. So I didn't expand more to fix the crossbite. To fix this crossbite, which you see here in the middle, I didn't expand the upper right molar. I took the mandible and I moved the mandible from here to here, and I stabilized the mandible with an artificial occlusion, which is this, acrylic resin bite blocks. Midline now is corrected. The molar are in class 1. The only thing, I hope he will stay in this position, because there is no stability in the joint. He wants to relapse. To build up the resin bite blocks, I use this wax on the incisors. It's a little piece of wax which I use to build up the composite bite blocks in the mouth. So I prepare the wax with the midline where I want, and then, of course, we polish the decidus teeth, we etch it very well, and then we build the posterior resin bite blocks, having this wax to keep the mandible where I want during the work. This is the same day when we did the bite blocks. Now I have to wait the molars to erupt correctly. So you see here without the bite blocks on the left, with the bite blocks on the right, you see the improvement in the mandibular asymmetry, much better. A little, very slight improvement in the profile. I move forward the mandible a couple of millimeters, maybe 4, 5. Here is the bite blocks. This is March, May, July, and the molars erupt in a good occlusion. The midline remained where I placed. 3 months. 4 months. March, July. The molars are going and touching in occlusion. But still, there is no COCR coincidence. At every time they comes in the office, I check the TMJ. July, still there is a shift. But the molars started going in occlusion. You see on the right, March, there is an open bite. July, the molars are touching. But still, there is a shift of the mandible. Here, we start having more stability. More stability. Here is July, below is July 2011. Mandibular shift. Here is below July 1 year after, 2012. I started with mandibular shift. It took 1 year to have a good stability. But now he is stable, doesn't shift anymore. The mandible is there. I'm very happy. I remove the appliance, take a look to the canines, the transpalatal bar to take advantage of the leeway. The premolars on the right are not really in full class 1. Let's wait. And this is the end of the transition. 3 more years, 2 years and a half after. Now is stable. You see a little bit of relapse of the asymmetry correction, but when the molars and the second premolars are in full class 1, also on the right, second phase will be very easy. Very easy. What happened is that he grew up very stable, very happy, still waiting for the phase 2. Do you think he wants to do a phase 2? He doesn't brush the teeth. It is impossible to perform a phase 2 if a patient doesn't brush the teeth properly. So it would have been impossible to do an orthodontic treatment during adolescence. But in my opinion, he doesn't need any orthodontic treatment now. He did half treatment, a limited treatment, only the early treatment, but this is enough. Okay, very fast, the last case. She came because of the diastema, huge diastema between the incisors. Wow. So, once again, frenectomy. Why? If you do a frenectomy, what do you think you can achieve? The diastema will remain. I see the frenum, I see it, but there is no reason to do a frenectomy. But she has a crossbite. She also is in full, as a full stability of the joint, narrow palate, asymmetrical palate, asymmetry of the mandible, asymmetry of the mandible. The mandible is asymmetrical, not the occlusal plane actually, but the mandible. The mandible is a little bit asymmetrical. Okay, and there is no shift, so I have to manage the position of the mandible with these resin by blocks again. There is a skeletal asymmetry. You can look for it and you can measure it if you do a CT scan, and you can measure how many things you want. But the problem is that she is not shifting. The problem is not the profile, the problem is the class 2 subdivision due to an asymmetrical mandible. So unilateral posterior crossbite without mandibular shift, mild mandibular asymmetry, but a huge malocclusion, and nothing in the profile to be noticed. Crowding is very mild in the upper jaw. What I want to fix, of course, is the occlusion. Once again, treatment started with an expansion. With the expansion, the improvement of the mandibular position was present, but not enough. She improved much more than what I would have expected. The crossbite fixed, and there is not a full class 2, there is a head-to-head malocclusion. I use the resin bite blocks, acrylic bite blocks, higher on the left to fix the midline. And then I waited November, July, March, December, 1 year. And now on the left, I see a nice class 2, class 1 occlusion on the molars. Very stable, takes 1 year sometimes to get a remodeling of the TMJ. I think this is what happens. Look, the miracle here on the occlusion, what you see out of the mouth. But look at the coronal cut. 1 year to have a huge improvement of the position of the left upper molars inside the periodontal envelope, not buccally tipped, very straight, well oriented buccolingually. And once again, I remind you that I expanded the palate and I was able to achieve a different movement right to the left. I like it, because it's simple, predictable, effective. Simple, I like simple things. Predictable, it works. Effective. It works for sure. She has to grow, and this angle will change during growth even more. Now is at the end of growth. This is the treatment. She came for the diastema. I expanded 1 centimeter, opened the diastema even more. And this is at the end of the transition. She has small teeth. The reason of the diastema is not the frenum, it is the small teeth. There are spaces between the premolars, spaces between the lateral incisors and the canines, spaces everywhere. Small premolars, small lateral incisors, small central incisors. It's not a matter of frenum, it's a matter of size of teeth. The occlusion is perfect. She is not interested in a phase 2 treatment, but she still complains a little bit. Even if I'm very happy because she did half treatment, I have a beautiful result. She complains a little bit about the diastema, but she has small teeth. So even if I do a frenectomy here, the diastema will remain. The problem are the small premolar, small lateral incisors. Oh, actually, the main problem is that she doesn't like the diastema, but the occlusion is perfect. The stability is out of discussion. The symmetry of the midline is not perfect. She needs a class 2 to move forward the lower left canine. But look at this. This is a beautiful development of the jaws, of the occlusion, of the nasal cavities. She was asymmetrical before. Also the septum, the nasal floor, the sinus, and of course she stays like that. But this is a beautiful way of growing. And look at this angle, they change continuously. Now he is much more symmetrical than during treatment. But still, I'm very happy, but she stays, I want my diastema closed. So maybe now it's time to do the frenectomy, because she wants the diastema closed. The main concern still is the diastema. At the beginning, it was a huge diastema. I expanded the maxilla, made the diastema bigger, but still there is a diastema. Is a matter of frenectomy? No, it's a matter of build-ups. Small teeth must be fixed, doing the teeth a little bit bigger. And here, Dr. Patrizia Lucchi, she's working with me. Tomorrow I will present her to you. She did a nice work, 1 hour. The diastema disappeared. She is very happy. Everybody is happy now. Me, first of all, because I did the right thing in the right moment, and I was able to reduce the invasivity of an eventual phase 2. Look, I corrected this huge malocclusion. At the beginning, there was no shift without cooperation and without touching permanent teeth at all. So, once again, we are not talking about expansion. We are talking about orthodontics. We are not talking about rapid palatal expander. We are talking about orthodontics. So, in conclusion, in front of a class 2 subdivision, the diagnosis is mandatory. Early treatment of a class 2 subdivision could be an overtreatment. Be careful when you have to find the right indication. Early stage of the mixed dentition could be the best time to intercept mandibular asymmetry. On the other side, if you have in front of a class 2 subdivision type 2 without crossbite, without crowding, wait the permanent dentition. The late stage of the mixed dentition could be a good time to distalize the molar with skeletal anchorage. Of course, this becomes natural if we need an early treatment for other reasons. Phase 2, at the end of growth, if the skeletal asymmetry is huge, could be a good option. Of course, when we talk about asymmetry, we are in the field of the art, orthodontic art. There is nothing reliable in the literature to allow us to do the best for our patient. So I've been talking about asymmetry, class 2 subdivision. Take-home message is that please don't waste your time in learning difficult things. What the best is to be able to perform simple procedures. High tech doesn't mean the best. If I am able to find a low tech, simple but effective procedure, I'm very interested. And diagnosis, no, not the high technology is the most important thing. We are working with the brain, not with the machines or with the appliance. And so we are waiting for the last part of the day, RP in the mixed dentition, tricks and tips and complications. So see you in half an hour, 25 minutes. Thank you for your attention and enjoy the break.